Thank you so much for the very kind introduction, and a special call out to the organizers of this meeting. Joan Hoffman in particular, who had a kernel of idea that we would do this session when I met her in Boston back in the Ice Age, pre-COVID era, at least 5 or 6 years ago. So this has come to fruition, and I'm very grateful to be able to share some of our findings of our work in Boston. This is also a little bit of a reunion for me. In the audience are several of our co-investigators, some of whom have gone on to greatness elsewhere outside of Boston. In particular, I point out Mario Santos, who's in Porto, and fabulous cardiologist there, who did some great work with us in Boston. So it's really gratifying to see some of our work with kernels in Boston grow and propagate to other countries such as Portugal. So thank you so much for having us. When the dean said he looked around the room and spotted people who don't speak Portuguese, I know he was looking directly at me. But obrigado is the one word I do know, so obrigado for the invitation here. So as you just heard, my mission today is to tell you a little bit about a project that was an offshoot of the NIH RECOVER project. This was a $1.4 billion project launched by the NIH, a U.S. congressional mandate to find a cure for long COVID. And although we've made some headway, it's not been perfect. Several thousand patients have been enrolled in that study. They've been well categorized in several different ways, and then increasingly categorized over time with further work, and some randomized clinical trials are just now getting launched. So I'm going to tell you about a little piece of this that we were involved in, and that was an effort to determine commonalities that Sue Levine just talked to us about between ME, CFS, and Long COVID. And I'll restrict my comments to my world, which is largely the exercise pathophysiology world. So what I'll cover is really two large categories here. One is some, I think, relatively established now notions about circulatory abnormalities during exercise in ME, CFS, and more recently in Long COVID. We'll attempt to link those. And then I'll end with a session that's really intriguing and late-breaking, and that is the notion that the skeletal muscle mitochondrion may actually be dysfunctional in both diseases and worthy of diagnosis and treatment. Diagnosis and treatment would be very, very different from the vascular abnormalities that we know about. But first, a tiny bit of history. There was a place nearby where we work with an interesting title, given what's come around here with ME, CFS, and more recently Long COVID, the Harvard Fatigue Lab. And it was actually in the business school along the banks of the Charles River, and they put many of the basic tenets of exercise physiology that we now know to be true on the map way back in the day. I was not part of this, a little before my time. This is what I am a part of, and several of the co-investigators here. This is in the basement of the Shapiro building at our hospital, the Brigham and Women's Hospital and Harvard Medical School. So this is an invasive cardiopulmonary exercise test, and I'm going to introduce it, and several of our speakers tomorrow will rely on this technology, and we'll tell you more about it. But in the way of an introduction, many of you may know about the non-invasive cardiopulmonary exercise test, which involves the mouthpiece in this gentleman's mouth, measurements of ventilation and pulmonary gas exchange. But what's special about the invasive part is two catheters, one in his left wrist, which is a radial artery catheter, and another in his right internal jugular vein and pulmonary artery catheter. And those two catheters, as you'll see, allow us a deep dive into the pathophysiology of these patients, without which, at least with current knowledge, we'd have no idea what was happening. So although it may seem intrusive, our patients are actually quite satisfied at the end of the test. We ask them regularly who is worse, the dentist or us, and 99% of them say the dentist with drilling is worse than what we do. Also, I know there is concern occasionally out there about precipitating post-exertional malaise with this test. I would reassure you that only a handful of probably the 3,000 cases that we've done have had post-exertional malaise that could be linked to this. It's a quick test, 5 or 6 minutes. Only the end is intense. Now, here's an overview of the diagnostic algorithm that we derive both from the non-invasive variables and the invasive variables. And I'm not sure if you can see this pointer. You can. So up here at the top is a non-invasive variable. It's a time-honored number that we get from a cardiopulmonary exercise test to tell us how impaired the patient is. It's the maximum oxygen uptake at the end of the exercise bout. And I'll quickly point out 3 other things that we're not going to talk about today, but they are very useful, and in deference to what Sue Levine said a few minutes ago about long COVID affecting a subset of patients with parenchymal lung disease, they would land here. With cardiomyopathies, the left heart, they would land here. And then occasionally pulmonary vascular disease, probably pretty rare in long COVID, and probably non-existent in pure ME CFS unless you had a prior abnormality. These things can be ruled out with this exercise testing: lung limit, classic left heart or right heart limits. Where we end up in this diagnostic algorithm are these 2 buckets in ME and long COVID, as I'll show you, a little bit of a preview. Something we call preload failure. It may not be a perfect term. It's one that we're working on, but I'll tell you why we call it that. And then peripheral abnormalities that may reflect both circulatory abnormalities and possibly mitochondrial dysfunction. I'll come back to all of this. We got in this business about 5 or 6 years ago with the help of Will Oldham, who's shown here. This was our first stab at all of this. We were being referred in an increasing fashion with referral patterns, patients with mystery reasons for exertional intolerance. We couldn't find anything wrong with the heart or the lungs. And when we did this type of testing, what we found was something very different that differentiated them from normal individuals. We have a handful of normal individuals who come to us with exercise intolerance, but we can't find anything wrong with them with the catheters. So this is something we ended up calling preload failure. The thing that differentiated these affected individuals with, yes, dyspnea, but also fatigue and orthostatic intolerance was low filling pressures on both sides of the heart. This is the right atrial pressure, and I would emphasize in the upright position. If any of you are doing supine right heart caths, you will miss this signal. And most important, at maximum exercise, not as apparent in the resting state shown here. So this is the right side of the heart, the filling pressures. They are lower, and these distinguish the impaired from the normal individuals, low VO2 max from normal VO2 max. And additionally, on the left side of the heart, we have a surrogate for the left atrial pressure, the so-called pulmonary capillary wedge pressure that we get every minute during this testing, and it additionally differentiates normal from different. The affected individuals, when we attempt to regress the time-honored VO2 peak or VO2 max and the cardiac output at the maximum exercise against the filling pressures, there was a relationship. The lower the filling pressures in these groups, the more affected the individual, and the way they're affected is a decrease in peak cardiac output across the board. But as it turns out, it's not quite as simple as that, and with the help of Philip Joseph, who is sitting toward the back of the room here today, we took a little deeper dive into the pathophysiology 2 summers ago, where we had an expanded database. We went from about 500 patients in that initial database to 3 times that number. And we looked a little more firmly, as it were, at exercise pathophysiology subtypes. We better defined those patients with ME CFS. And additionally, we were becoming aware that a fair number of patients referred to us with preload failure had by skin biopsy something called small fiber neuropathy. Small fiber nerves, if you're not aware of them, they've been around forever. They mediate pain, nociceptive fibers, unmelanated fibers. But more recently appreciated is that they also have an autonomic role. And amongst other things, they regulate blood vessel tone and therefore blood flow systemically. So we began to systematically look at these patients in a slightly different way. We divided these patients with well-defined ME CFS into 3 tertiles of blood flow versus VO2 slopes. So here are the 3 tertiles. Here's a group of normal individuals, I think 16 of them in all told. By definition, we had these 3 tertiles. The interesting phenotype that fell out of this was this group in the red. And this has been defined, or something very similar has been defined in POTS, postural orthostatic tachycardia syndrome, with an upright tilt table test, low flow at the left end in the blue, high flow at the right end. And the high flow is what got our attention here. So they have a higher slope of cardiac output versus VO2 during incremental exercise. They have similar depression of VO2 peak. Their cardiac output is about the same, is a little bit higher than the low flow group. And then the other hallmark of this patient group is impaired systemic oxygen extraction. And I'm going to keep coming back to that term, but what I mean in English, not Portuguese in English, is that this is the ability of the muscle to take up and use oxygen that's been delivered to it, in particular at peak exercise. They all have preload failure. This is ubiquitous in ME CFS. So this is the group I'll focus on, the high flow group, and I'm going to keep coming back to this measurement of oxygen extraction. This is the arterial oxygen content. This doesn't change in these individuals. This is the mixed venous oxygen content at the end of that pulmonary artery catheter that we're measuring as an index of extraction. I want you to remember, please, the type of blood flow we're measuring with the catheter is pulmonary blood flow. This is the amount of blood going through the lungs, and then we measure how much oxygen is extracted. So what we have found is this subtype with a lot of pulmonary blood flow and very poor oxygen extraction. I'll come back to that in a second. We looked at those who had had skin biopsies for small fiber neuropathy and those who had definite or probable small fiber neuropathy by a single biopsy, tallied up to about 44% of patients. This is very similar to fibromyalgia and very similar to POTS. So we think this is the same animal. One second thought here, just for a second. This phenomenon of high pulmonary blood flow and poor oxygen extraction is the hallmark of left to right shunting. This is ineffectual blood flow that goes out to the periphery of the exercising human being that is not being taken up properly by the muscle, and it goes around and around in the lungs. It's ineffectual. So this is peripheral left to right shunting. These are late-breaking data, and kudos to a variety of our co-workers here listed down below, but in particular Johanna Squires, who's going to present this at American Thoracic Society in a couple of months in San Diego. What we found was something interesting according to sex. So the peak VO2s in females and males in an expanded database of patients, 287 males and 79 males, recent data, has a depressed peak VO2 about 80% across the board, modest depression of VO2 peak. They all have, most of them have preload failure, low right atrial pressures at peak exercise, and there's no sex difference. But if we look at this high flow versus low flow phenomenon, there is a sex difference. Females are much more likely to have this high blood flow at peak exercise, here expressed as a percent predicted, and they have a high slope of cardiac output to VO2. So I suggest to you that this is one example, perhaps, of a major gender difference or sex difference that affects the systemic circulation. We don't know the reasons for this. A lot of hand-waving about autoimmunity that Sue Levine mentioned earlier, more predominant in women, perhaps more inflammation, perhaps more microclots, perhaps an influence of estrogen metabolites and even progesterone on the systemic vasculature. So this is something that we hope to pursue. All right, so what about long COVID? So we're informed by Indy Singh, who's shown here. This was a study of a smaller study. He'll present to you a larger subsequent study, I think, tomorrow, of long COVID. So these were patients who were at least 6 months out from their acute illness. They did not have any heart or lung disease, so this is the subtype that Dr. Levine mentioned, without heart or lung disease that could be documented. We had 10 of them, and we compared to 10 normal individuals. And some of this will look frighteningly familiar. This is a commonality, I believe. So VO2 peak is depressed, but oftentimes just modestly in long COVID. The pulmonary blood flow, cardiac output, is actually the same as the normal individuals. And what is wildly different is impaired oxygen extraction peripherally compared to controls. There was probably a type 2 error here. I believe they had preload failure with low right atrial pressures as well. Come back to that in a bit. So this is where they end up in our diagnostic algorithm. Both ME, CFS, and long COVID have elements of preload failure or low filling pressures that are abnormal, and additionally, at least a subset and a predilection for the female sex of impaired systemic O2 extraction. So we would have an interim conclusion here that at play in the exercise pathophysiology of both ME and long COVID is something we would call neurovascular dysregulation because of its association with small fiber neuropathy in these vascular abnormalities. So that's part one. Part two is shifting gears toward the mitochondrion and the muscle. We began to get into this with a couple of other collaborators here in the audience today. This is Mario Santos and Rudolf Oliveira from Sao Paulo, and Katie Melamed, who's now at UCLA in the pulmonary division there. And we basically took our invasive exercise algorithm, such as it was back in the day. We ruled out heart and lung disease, and we ended up identifying a subset of patients whose exercise intolerance appeared to be exclusively due to impaired systemic oxygen extraction. We learned later that many of them had ME, CFS. And this is what they look like with a direct measurement at the tip of that pulmonary artery catheter. This is the mixed venous O2 saturation, which should go down, down, down to low levels, about 28% at peak exercise if you're normal. And these individuals failed to do so. So this is impaired oxygen extraction. We were reminded by the UT Southwestern group, who had a fabulous neurology group doing both exercise and muscle biopsies, that the hallmark of a mitochondrial myopathy, a muscle problem whose major issue is the mitochondrion, is impaired systemic oxygen extraction, shown over here. They were able to quantify back in the day the mutation load of muscle mitochondria, shown here. And the more severely affected shown out to the right here, and what you can see is then there is failure to widen this AVO2 content difference read, more muscle mitochondrial abnormalities, more impaired systemic oxygen extraction. So we began to think that perhaps the muscle mitochondrion was at play and perhaps responsible for some of the oxygen extraction problem, perhaps in addition to left to right shunting. This was reviewed recently by the group at the Griffith University Hospital in Australia. I can tell you what they say at the very end. They reviewed 19 studies in this review recently and concluded we don't know enough about the mitochondrion in ME/CFS. So we've taken a couple of initial stabs at this. One was immediately pre-COVID. We had 11 patients with poor systemic oxygen extraction, shown over here. These are the numbers and their VO2 peaks here, with muscle biopsies from the thigh sent to Baylor, frozen, and interrogated for electron transport chain abnormalities. And all but one of them had something called citrate synthase deficiency. This is thought to be a global marker of mitochondrial dysfunction. So we think perhaps we're onto something. We followed that up with a randomized placebo-controlled clinical study with a company named Astellas from Japan. And we were targeting 40 patients with ME/CFS with poor oxygen extraction. We got to number 32, and the company took an interim look at how well their drug was doing. The answer appeared to be not so well, and we stopped at 32. But along the way, we were able to get muscle biopsy results from 32 patients. And you can see the randomization into placebo or the drug, and here are the baseline values. This is the citrate synthase activity shown here, 61% here, 72% here. every one of the patients that we recruited with ME CFS and poor oxygen extraction on an invasive CPET had citrate synthase deficiency. So perhaps there's something there. What about long COVID? I have to turn back to Indy Singh and his paper, and I would remind you that what he found as the hallmark of long COVID in the smaller study was impaired systemic oxygen extraction. So I would hold out to you that perhaps this part of this is left to right shunting, but perhaps the other part is impaired oxygen extraction due to a mitochondrial defect, again, whose diagnosis and treatment is totally different. Last little blast here, this is from a recent study that many of you have, it had great notoriety in the press. This is the Amsterdam group whom I saw present at Santa Fe last fall, and in Nature Communications in December they published this paper on long COVID, and they took several different angles to define mitochondrial dysfunction per se. So they had time-honored VO2 peak, no surprise it was down a bit in the patients with long COVID. But additionally, they had near-infrared spectroscopy, and I'll just cut to the chase and tell you this is a measure of systemic oxygen extraction in the exercising muscle. It was depressed. Additionally, they did muscle biopsies, and they found an upregulation of fast-twitch glycolytic muscle fibers in the long COVID patients. These are patients without heart or lung disease. So fast-twitch glycolytic fibers, not so good for endurance, not fatigue resistant. So you could begin to read fatigue issues there. They also looked at replicate muscle biopsies after inducing post-exertional malaise with prior exercise. They had two measures of mitochondrial function, one OXPHOS capacity and the other succinate dehydrogenase activity. And you can see that in the long COVID patients on day 2 after exercise, but not in normal individuals, there was a depression of mitochondrial function. So mitochondrial dysfunction may play a role in PEM, would be one of the potential take-home messages here. So I would end by saying that both in ME and in long COVID, we have evidence of this preload failure with low filling pressures. We additionally have this potential left to right shunting, but I would add to the list mitochondrial dysfunction. So here's our final conclusion. For those of you who are interested, meaning our collaborators and I, published this paper in a cardiopulmonary journal, Chest, last fall. This covers much of what I've said and more. Here's the take-home message that in ME and long COVID, there's probably more in common than not, at least in the exercise world. So I will end by thanking a few people, Aaron Waxman, who helps us with catheter placement, the aforementioned Philip Joseph and Indy Singh and Johanna Squires, Sarah Alzair, who's one of our young investigators going off to medical school, and then the Mass General Harvard ME Consortium organized by the late Ronaldtompkins, Donna Felsenstein, a famous and incredibly talented infectious disease doc. Our computational group was represented here by Wenzong in the audience you'll hear from tomorrow, and a fabulous group also, Montreal, doing transcriptomics for us. Maureen Hansen at Cornell, Jonas Bergquist, whom you'll hear from tomorrow, is the granddaddy of this group, and Ron Davis out at Stanford. A special call out to Linda Tannenbaum and Open Medicine Foundation, whose funding has helped leverage much of this. I thank you. Obrigado.